Good afternoon, everybody. Cures 2.0, which the relatively recent history has been a little bit bizarre. Budget year 2011-12, Cures was defunded by the legislature when they defunded Bureau of Narcotic Enforcement and my bureau, the Bureau of Investigation and Intelligence. It's about 6 months later, December of that year, they realized, oh my gosh, Cures is unshepherded in all this confusion about the consolidation and the defunding. And they couldn't lay me off because I was just too darn old. So they said, oh, well, this is perfect. We need a fall guy who's, closest to end of life to run this thing. So we'll put Mike and Cures together. So that's how that happened. And then we went straight into, because we had no money, legislature decided, well, this is a good time. We'll make registration for Cures mandatory in the clinical community, and we'll bolster up Cures. So they generously gave us $3.3 million to build a new system. And at the same time, they required you to register to use the system. So in our business analysis and approaching this, when I first came on to Cures, not knowing anything about the epidemic or medical technology or anything, one thing I did notice immediately is because I got calls from several doctors saying, hey, I like to use Cures prospectively for potential patients, and if they look problematic to me, I just won't accept them. And then I also got calls from investigators who said, well, the most prolific users of Cures that we're aware of are the pill mill guys who are screening us to make sure we have a good long drug history before they take us on as a patient. So my immediate concern became oh my God, I hope this tool isn't unwittingly producing mal-effects, unintended consequences. So we wanted to make sure in building the new Cure system that we put some clinically assistive features into the application that in fact imbue a mindset to bolster safe prescribing and also give a way to ensure that even after the prescription occurs, that there is a manner to follow through and make sure the patient stays in a good, safe standing. So knowing that big data analytics, the cost of that was coming way, way, way down, we engaged SAS Fraud Framework, who we used to use in the intelligence business a lot. And they came in, consulted with us, and they built us a fantastic system. One that is capable of every night folding in the 150,000 new prescriptions that come in daily to our terabyte of existing data and systematically deduplicating all of that, which is no small feat unto itself because, as you know, prescription data is merely name, date of birth, and address. So we have to separate out our John Smiths as the appropriate John Smith entities, all individualized. So when you consider that even Mike Small, well-intended, could be Mike Small, Michael J. Small, I could use Street Avenue Way, and a normal computer system would read those as individual person entities. We have to deduplicate that and use algorithms to do that. So first, the system deduplicates. Then it parses out the contemporary prescriptions based on date filled and day supply. Then it calculates all the medicinal values of all contemporary prescriptions. And this basically is the flow for those processes. And what we decided to do is to present safety messaging alerts that are refreshed every single morning for prescribers. So say you consulted Cures and safely prescribed that there is a good prescription history there that had no contraindication for your prescribing something. And say patient goes in the next subsequent couple days, maybe sees a psychiatrist in another healthcare setting that you don't share your electronic health records. So then benzos are prescribed. Up till now, you had no way of knowing that for these disparate systems of these cumulative prescriptions that might be affecting the patient. So now if you bother to check Cures, we produce alerts, and they're on the order of 250K a day. that are generated. And I'll tell you that if a patient is aggregately receiving more than 100 morphine milligram equivalents a day, all the prescribers will receive that alert. If the patient is getting more than 40 of methadone, they'll get the alert. If the patient's on both benzos and opioids, an alert will be generated. And if the patient's on the 6, 6, and 6 high prescription seeking formula, they'll get an alert. And that's admittedly high, but the more realistic formulas, like the 4 doctors, 4 pharmacies in 12 months, produce so doggone many alerts, we're afraid of alert fatigue. So we thought we'd give you the low-hanging fruit there. And if they've been on opioids more than 90 consecutive days, we'll generate an alert for that. So what we're hoping is that you'll not only be able to safely prescribe, but you have this rearview mirror a way to monitor your patient and make sure that they don't fall into an at-risk category under your care and your fellows' care. And should the alerts come up, the Cure system also provides you a manner to communicate with those other prescribers within our secure Cures environment, because we recognized again that if doctors are in another healthcare system, you don't have an email system that you could easily look up a directory and talk to one another or get the phone number. So we provide that peer-to-peer communication capability, which is on that page there. And also, if you're an addiction treatment doctor and you engage in compacts with your patient, and by that I mean, okay, the only way I could treat you is if you obtain prescriptions for me and me only, and we're going to write a contract about that. We give you the capability of flagging those patients in the system, because just in that off chance the patient presents himself to another clinician, they would have the opportunity to see that, and they can contact you right away and say, hey, Johnny's trying to get drugs from me. I think you might want to know about that. And lastly, delegation authority. We do finally allow you to have your staff, you can designate staff to launch queries on your behalf. Now, admittedly, the responses will come back to you, the clinician's account. That's because I have 1,700 lawyers that tell me that's all I can do. So, we did the best we can in that regard. So I don't need to show you the system. Cures, basically, I can tell you a little bit about, we have 3 mandates by statute. Cures is to assist clinicians prescribe and dispense safely to individuals under their direct care. Okay, so it doesn't mean that quality assurance level officials at the hospital can access cures and look for outliers. It means only we can help the clinician directly taking care of a patient prescribe and dispense safely. Cures also does assist the regulatory boards. The regulatory boards have unfettered access to our 7 years of Cure data for their mission. And then Cures does also support law enforcement by statute. And in fact, California has the longest standing PDMP program in the country. The California PDMP started in 1939 on Schedule 2s. And we used to have the big giant warehouse full of paper that looked like the Indiana Jones warehouse, to prove that. It wasn't very good data management, but they did collect all that paper. But that was used for diversion purposes. And a lot of people ask, why is the PDMP in a law enforcement setting in California? And it's because diversion's been a longstanding problem in California, and all the other PDMPs in the countries are just Johnny-come-latelys trying to resolve the epidemic alone. So in 20 years, I can tell you this epidemic's going to subside, if for no other reason that our doctors are going to be very much better educated about the pitfalls of long-lasting opioids, that in fact they can be addictive as opposed to being taught that they are not addictive. And the patient population is going to be a lot better educated. So it's this instance of the epidemic I predict will end within 20 years unless we do something better and end it sooner. But nevertheless, we'll always have diversion. So a law enforcement setting for PDMP is not necessarily a bad thing, especially in such a drug usage state as California, which has an extremely high demand for street drugs. So cures, stores and reports all Schedule 2, 3, and 4 dispensations in the state. And we shepherd the data. We don't touch it. We don't add, modify, or delete it. I need to be able to testify in court that the data in cures is the data that I receive, regardless of whether one of 3 actors contributing to that report is a liar or a cheat or a swindler. There's 3 actors that can affect that: the patient, the dispenser, and even the prescriber. So we need to preserve the data as is for adjudication purposes, and we do that. And lastly, to be assistive to the public health effort, because we recognize that this is very important data for data-driven stratagem and programs and measures for success. We also invoked in the new system a systematic development of de-identified data sets. So we now have the capacity to produce 58 county de-identified data sets on a quarterly basis, and we are happy to share that with 20 or 22 or 24 existing counties, and we invite all the other health officers, remaining health officers state, to get a data share agreement with us, and we can deliver that data to them to help them in their strategy path towards resolving this epidemic. So with that, I'll leave it to Jose to carry on.
Good afternoon, and I'm sure some of you must be asking, what's a public defender doing at a conference like this? Well, what I wanted to talk to you about today is the different ways that opioid epidemic has actually touched all of our lives in terms of the criminal justice system. People like to see the criminal justice system as the prosecution, the defense, good guys, bad guys, and this sort of very stark black and white reality. It's not. The reality is, why did I, as the public defender of Marin County, try to get our office and be very much a part of RX Safe Marin, which was a community created initiative that sought to address this problem through very real data, through very real stories, and through very real impact? It's because the reality is that people of color see me more than they see many other people. And the reality is that the criminal justice system has changed. These systems before, and many of you know about these systems before that had been very stark and basically led to prosecution, defense, incarceration. Prosecution, defense, incarceration have started to change. And they started to change with the vision of Janet Reno many years ago in Miami, when she was the Dade County District Attorney and saw all these people really in a cycle of drug addiction. Just saw it over and over again. And she had this idea, along with other people, to create these things called drug courts. And therapeutic courts that sought to get to the underlying causes of crime and the underlying causes of the things that brought people into the criminal justice system. And she got federal funding, and then when she became the U.S. Attorney General, she continued to fund those projects. What that wound up doing is creating the notion of teams within the criminal justice system. Teams that work together: prosecution, defense, drug experts, treatment providers, a judge. There was this whole notion of creating a staffing. We had all of you that are in public health, staffings are like, it's what you do. I mean, you get together, you see a problem, you try to solve it together. That wasn't what the criminal justice system was doing. And so those of us that got involved in drug courts and we got involved in the different kind of work that was being done saw the absolute energy and achievement and accomplishment that could happen when you had this collaborative approach to problem solving, something like drug addiction, mental health, veteran issues, all of these things where you could really have a guided, focused, expert sort of view of the problem. For us in Marin County, the opioid epidemic was real. And it was real to be honest with you, the family of the rich, okay? It became very real because we started seeing kids that looked like they were the homecoming queen, homecoming king. They looked like everything you would expect to see on a poster of the next president of the United States. But in fact, what they were doing was starting to go into medicine cabinets and taking Oxycontin here, Norco there, something else here, something else there. And we started seeing these beautiful kids, some of them, at high-priced schools, Catholic schools, and all these other places, all of a sudden becoming addicts, real bad addicts. And one of the things that brought us all together when we got this coalition going in Marin County was the stories of parents who saw their children die on them, and they never had a clue it was coming. Or parents who found out that their daughter had been addicted to prescription drugs and all of a sudden found herself taking her car or a bus down to the Tenderloin in San Francisco to buy heroin because it was cheaper. All these stories started to give the data a real meaning. And when we started to put the data together with the notion, as Dr. Matt Willis, who heads our initiative, once every 2 weeks somebody dies of an overdose in Marin County. I'm sure if you looked at your county and said, what is the frequency? What is the reality? Those stories become very real and they start to coalesce and people start thinking about it. We were very lucky a few years ago that Matt Willis came to our county in Marin as an epidemiologist and started looking at data and started seeing some of the issues that were going on where there was prescription misuse or overprescription at a point that it was creating a supply in our community that was being misused. And so he brought us all together as a community. Imagine a room full of people from all walks of life. Public defenders, social workers, pharmacists, doctors, store owners, community advocates, reentry workers for the sheriff, DA representatives, Health and Human Services representative on housing, everything. Just brought us all together in a room. Basically just started telling us the data and the stories. And you couldn't sit in that room without being impacted and saying, I want to do something. I want to do something. And because of the work I had done as an online public defender before I went into administering offices, I gravitated to this process. I grew up in a community of color, a portion of our community in Martinez, California that was Latino, that had African Americans, and I saw what poverty did. And I went into public defender work basically as a poverty lawyer. And my whole thing was, my mom told me, try to make people better. See what you can do. Try to do something good in the world. And as part of that, when the impetus of the coalition we created, it really was, let's try to do something good here. And ironically, it was a high school intern, because I have an internship program in Marin County. And we were talking about young people being, oftentimes the ones that are dying because they have the least information and the most impulsivity. And I brought her to the gathering. She was the only person probably under 25 at that meeting. There were no other young people there. And here we were trying to address an issue of young people. And so as I sat around and she joined us and talked about it, I said, what do you think? She goes, where are all my peers? And so I had her do a paper after the conference and said, if you could give a notice to the adults, what we can do to help kids not do this. And she says, yeah, I'll do this. I'll create this policy paper. And she did. And as part of our coalition, I gave it to our coalition partners, and we were able to see some of the things they were doing. But one of the things that surprised me as she was doing her paper is she spoke to her parents, who were both doctors. And he says, what is this opiate coalition all about? And he talks about the overprescription. He goes, my God, we give those to people like candy. I can't, some of my patients who are, in their 60s through their 90s, they have standing prescriptions of 100 pills apiece. And then all of a sudden, when you started realizing the doctors had actually been trained, and they told us they had been trained, in the last decade to alleviate pain. And that somehow these pharmaceuticals were going to be the basis of this pain-free quality of life situation. What they never anticipated was the amount of drug that would get out there through prescription and the misuse that could happen. I've talked to young high schoolers and said, Would you be able to get pharmaceutical drugs in your high school? Mr. Varela, I could walk at recess and have 4 pills within 20 minutes. I mean, these kids are trading it in the same way they traded Pokemon cards when they were young. This is a reality. And the more I dug into it, the more I realized that as a public defender, I needed to know this. Not only to warn our juvenile clients who might be seeing themselves on the edges of addiction, but the reality that we as first legal responders in a lot of ways would be able to assist our clients. You know, for me, helping somebody out of the throes of addiction is probably one of the greatest victories I can have. I've won victories at trial. I've won victories, you know, that got newspaper coverage. But I tell you that the greatest thing I ever experienced was when a mother from Indiana called me up, and I was representing her daughter, and she says, "You got to help me. Please help me. I have been trying since she was in high school. You've got to do something. You've got to help me." And it really touched my heart because the mother was a nurse and a single mother and very concerned about her daughter. And, you know, in public defender work, you can't save everybody, but sometimes something grabs and tugs at your heartstrings. And I started just visiting her every day. I started visiting her often as I could while she was in custody and talking to her, and basically talking to her about how much her mother loved her, how much her family missed her, how much they missed that 11-year-old girl that they once knew. And we started talking. And while she did her time in custody, she actually cleaned up and wound up starting the process of sobriety that probably now is into 20, 30 years of sobriety. And it was that achievement that said, we can do this as a community. These stories are going to incite us, embolden us, and spiritually sustain us as we go through this coalition. And I think one of the reasons I'm here is to tell you, yes, we do in our law enforcement committee, we do the standard stuff. You know, we learn about cures, which is incredibly important and going to be an incredibly powerful tool with regard to being able to track and get ahead of the misuse, which is going to be great. And a lot of the pharmacists have told me personally and told our coalition personally, thank you, because it's allowing them to be able to do something, you know. And so they're very happy with that system. And we have, you know, suggestions. You know, our DA said, you know, if I learn that somebody's being charged with possession of drugs and I learn that they have a prescription for it, I'm going to write a letter to the doctor and let the doctor know that this person was arrested and part of the arrest. I got to tell you, as a defense attorney, my collar went, you know, and I voiced some of my objections, said, does this deal with medical privacy and things of that nature? But we were able to talk out a lot of those things in that process. And our DA, as far as I know, hasn't really misused that sort of initiative that he wanted to do. But he wanted to make sure that doctors were aware that there was an outcome to their signing that paper for prescription, that an outcome could happen, not just of pain relief, but of sustaining addiction. And so in a lot of ways, it was educating all of us. It was bringing us up to the fore. Our law enforcement subcommittee includes a public defender, includes sheriff officers who are part of the task force that does sweeps and undercover operations. It includes a health and human service worker that's very involved with drug addiction. It includes the reentry officers. And the thing that I also really appreciate, it includes a lot of chiefs of police from different jurisdictions. So we're all getting to talk about things. You know, we're all voicing ideas about maybe we can have, you know, very much like these pamphlet credit card pamphlets that we can share with teens, that when they open it up, they can see some of the data and statistics that really cause you to take a back seat with regard to this. But I think the greatest thing that can happen is the energy of a community. The energy of community. The reason I'm speaking here is because this is what we have to do. If you're simply a coalition in a room, you will not do anything for your community. If you are a coalition that's going to community meetings, that's going to Pete's Coffee in the morning and talking to people about this work, who, when you're at Pete's Coffee and you introduce Dr. Willis to all these other people and tell them what great work they're doing, when you go to Starbucks, when you go to Rotary clubs, when you go to all these things, that's how this message is going to get out. This is how these coalitions work. And this is how, as law enforcement, public health officials, and caring citizens, we can address a problem that, if we don't tackle right now, could get really, really bad. Peace.
Thank you. Thank you so much, Jose, and also Mike. We're going to come around with the microphone for people here who have questions. I do have a question, though, coming in over the phone, sort of, for one of you, which is there data on numbers of medications that are diverted to the street, prescription opioids diverted to the streets?
I don't know any really good way to count that. There's no official tally of diversion, so there are drug seizures, but whether they are separated out as diverted drugs versus illegal street drugs, I don't believe so.
Jim Merkitis from Stanislaus County. With Proposition 47, where people aren't incarcerated, even for a short period of time, you tell the story about the young lady who had an opportunity to get that first step, and either through you or maybe a court-mandated program. There's a frustration out there where people aren't able to get that first step or get into a drug court. What are some of the strategies that maybe you're using in your county that we could duplicate in some of our counties where we're having that issue?
That's a great question, because it's one that's coming up and sort of has a reaction from law enforcement officials that this is not going to be an incentive. I think one of the things that we're learning is what the foundation for response is. And to give you an example, our probation department has taken on initiatives with regard to programs like Thinking for a Change, which is a cognitive behavior program. It's taught in the jail and it's taught in the community. And the goal really is to be able to, and when people go through these things and they graduate, in fact, I'm going to a graduation in the coming week where 5 people from our jail are graduating from this cognitive behavior program. The first thing they say is, why didn't anybody ever tell us this? Why didn't anybody ever tell us this? The other thing our probation department is doing, and in fact, they invited us, the public defender's office, to be involved in their training, and that is on motivational interviewing. You know, to motivate somebody to get treatment is incredibly hard. Okay? Prop 47 or not, it is incredibly hard to get that point of clarity where that person knows. And I've talked to my clients who have gone on to sober lives or to lives that are well sustained with mental health medication and things like that. I said, what did it take to get you there? She said, Mr. Varela, you got to keep looking. You got to just keep looking. You got to keep talking. And one day you're going to see it. There's going to be that point of clarity. You don't even know, but all of a sudden they're going to look you in the eye and you can say they're getting it. Once you get them there, Mr. Varela, get them to treatment, get them to have a cup of coffee, have them start talking to you. Because once you start into the depth of that point of clarity, you're going to be able to get to them. So I think a lot of it is going to be our responses to it. I also think that we can create, even within Prop 47, incentive-based processes that allow us to encourage people to go into treatment. You know, one of the things that we oftentimes think are successes in the criminal justice system is this whole notion of incarceration. And while that may be the road for the violent and those close to incredibly violent crimes, those are real. But what we found at the juvenile system and in the drug court system and others is if you can create incentives that are meaningful to the person, that those things work. And what can that be? You know, some people talk about movie tickets, da-da-da. Believe it or not, oftentimes it's a very unique incentive. I'll give you an example. We had a young man who refused to take his medications in mental health court. I won't share his name because you all know about the privacy laws. But he just wouldn't take his medications. And the judge says, well, I'm going to put him in jail. I said, let's look at another alternative. Let's look at a strength-based incentive that may be meaningful to this person. And he says, well, what is it? Well, let's talk to him. Let's find out what he likes. And all of a sudden, you know, he says, well, you know, the guy's actually a street artist. The guy does this. And so the judge says, okay, we'll try it. Let's see what it is. He says, I'm not going to make you write an essay. I'm not going to make you go to jail. I want you to come back next week with an artwork that exemplifies why you should take your medications. why it's good for you to take your medications. The following week, he comes in with this artwork that he created out of street recycled material and literally sat and cognitively told us why it was good for him to take his medication. And the judge still hangs that artwork in his chambers. See how the paradigm changes? See how you have to go outside and say, I have to think about this differently. Because it's really easy to go back to our silos. Incredibly easy to go back to our silos. It's incredibly hard, the road we're about to take. Because the road that we're about to take is actually trailblazing. Each one of you is a trailblazer if you guys are going to do this in your coalitions. Because you have to think outside of the box and actually create a whole new lid to open up. So with Prop 47, I think foundationally we have to work at motivation, incentive, and ways to measure compliance and measure outcomes and success. Because nothing, if it's just verbiage, is going to work. The thing I like about what we're doing with RX Marin is we're measuring it. We're making sure we measure things because everybody has good intentions. If it doesn't result in accomplishment and action, we haven't moved forward.
Karam Durrani from San Joaquin County. I have this question from Mike Small, and that's about the cures. I have a couple of questions. Why is it Cures 2? Was there a Cures 1? And are you expecting newer versions of Cures? Because there was a heavy push on the legislation on making it a mandatory thing for all prescribers to refer to Cures when prescribing any controlled substance. I know now everybody's mandated to register to Cures, but is that mandate still there that when I am prescribing a controlled substance, I have to consult with Cures or not? Thank you.
There was a Cures 1, and it was, anybody who's used it knows how fragile and interrupted it was frequently. It was not nearly robust enough to deliver the legislature's vision when they passed SB 809 in 2013. And I think there was a long-term intent to achieve mandated use of the system. So when we got the monies to build Cures 2.0, we built it sufficiently robust to accommodate such a mandate such as SB 482, which is on the governor's desk right now, that would require mandatory use of the system. We're ready for that and can accommodate that. I don't think we're going to get money from the legislature again anytime soon, so we are trying to think a little bit out of the box to achieve other things we need to do, such as I really want to have our Cure system be interoperative with healthcare systems throughout the state. So a sign-in into the native healthcare system is a sign-in into Cures, so there's not that waste of time finding Cure, signing in, making a query, and getting out. So the workflow is improved and induces more use of Cures. And we're fortunate to be engaging with the San Diego HIE right now and developing a pilot to do that because they approached me and offered to pay my end of it. So, we hope to develop a universally adoptable schema where any other healthcare system that wants to join in after we have proven success of that pilot can do so.
Yeah, this came up in the last one, and this is around the drug court programs. And so this being the opioid conference and medically assisted treatment, one, do you allow medically assisted treatment clients into your drug court program? And if so, how do you coordinate that and monitor their participation?
I do believe that there is, especially for methadone substitution, they do allow them into our drug court. But I'm going to be honest with you, I have to actually look to see whether they've changed the guidelines with regard to that. But most of the time, it's that our treatment providers who have substitute sort of drugs are the ones that are supervising that and checking levels and doing things of that nature. And so that continues to be a controversy, but I do believe that we did allow people who were going through substitution from opiates to something else into drug courts.
Hi, Rob Oldham from Placer County. Mike, I guess the question is for you. One, just thank you for your struggle over these years, and it sounds like maybe you now like have the resources that you need, which is kind of a leading question. I know your boss is running for Senate right now, and give you an opportunity. I mean, you said you feel like that you're ready if the governor signs this bill. Will Cures have the resources it needs, and what else do you think that you would need in order to make this kind of a workable system, including kind of I know the system is better. I know one of the issues has been you having enough staff to answer the phones and have voicemail set up and that sort of thing, and just kind of, if you feel like that you have the resources you need. Thanks.
Well, coincidentally, this legislative session, the legislature did appropriate money, so I can have program staff now. And in fact, they did it in a way that it doesn't even require a Department of Finance approval. So I think there's a recognition that we need some staff, and we will be getting that as soon as we can go through the whole personnel process.
Thanks. I think we're just at about the point to wrap up. As I mentioned earlier, we are going to have another session in this room, so please don't leave, but do fill out your evaluations. I just wanted to reflect really quickly. I think both Mike and Jose talked about kind of crossing traditional silos and barriers, and I think that's work that all of you are engaged in, whether it's working between primary care and specialty SUD, working between the healthcare system and corrections, working in Mike's case trying to achieve interoperability between Cures and native healthcare record systems. And it's really hard. And as Jose said, it would be a lot easier just to stay in the systems that exist. So I think that's a theme across everything we've been talking about today, and I just want to applaud all of you because I know it takes a whole lot of courage to try and build bridges across and to create new solutions to very, very old and entrenched problems. So with that, I want to thank both of our presenters. They'll be milling around and available for questions, and thank all of you for your participation.